Back to where we left off. Sorry about the end of the last lecture. I was getting a little distracted there trying to multitask, so I figured I should just stop and start over, and that's exactly where we are. We're continuing with our discussion of glomerular filtration and the process of urine formation, and we were talking about different types of pressures. One including the net filtration pressure. Really, this equation here that's in red, the net filtration pressure, NFP, that's the most important equation that you need to understand. Notice I said understand. You don't really need to know how to plug and chug numbers into this. This is not a diagnostic type of class where I'm going to give you the glomerular blood hydrostatic pressure, GBHP, and then you'll have to, calculate the net filtration pressure from that. I'm not going to do that, but it is important for you to understand the entire representation of this equation. So let's talk about it. Net filtration pressure, again, I'm focusing right here. Net filtration pressure itself is going to involve a number of different pressures inside the glomerulus. So remember, the glomerulus is that network of capillaries inside of the nephron, which is the functional unit of the kidney. So the glomerular blood hydrostatic pressure is the pressure of blood inside the glomerulus. The purpose of this is to push the fluid through that membrane into the capsule. I like to think of that GBHP, that glomerular blood hydrostatic pressure, as kind of the inertia of blood flowing through those arterioles, flowing through that afferent arteriole, and then the blood slams into those podocytes of the glomerulus, and all of the junk is knocked out of the blood. That's kind of how I think of it. And then that glomerular capsule kind of acts as a catcher's mitt, catching all of that junk that's been slammed out of the blood. So the glomerular blood hydrostatic pressure, that's a mouthful, GBHP, that is that pressure of blood inside that glomerulus. The CHP is the capsular hydrostatic pressure. That's the pressure of blood within the capsule. So after the solutes have kind of been slammed out of out of that glomerulus itself, the pressure of all of those plus the solutes is going to equal that capsular hydrostatic pressure. It's much lower than the glomerular blood hydrostatic pressure. And finally, you have the BCOP, which is the blood colloid osmotic pressure. That is the kind of pullback of fluid from the glomerular capsule. So this BCOP is kind of the opposing force to the GBHP. The blood colloid osmotic pressure is going to pull fluids back into the blood. Ultimately, this is a kind of give and take of pressure in and pressure out, and that's how we get that formula for net filtration pressure, NFP. So let's talk about the process. That afferent arteriole is much larger in diameter than the efferent arteriole, and that diameter difference is going to help raise the blood pressure in those glomerular capillaries, and any changes in those arterial diameters is going to change the net filtration pressure. If you're an individual suffering from chronic hypertension, chronic high blood pressure, that chronic dilation of those afferent arterioles is going to wear away your kidneys very quickly. Lots of people that suffer from hypertension also eventually suffer from kidney failure as well. So here's the entire apparatus as a whole. You can see the afferent arteriole much wider in diameter than the efferent arteriole. So the blood's coming in this way from all of those arterioles radiating throughout the kidney. The blood flows through here and then slams into these podocytes. You can see the podocytes have lots of filtration slits. All of those extra solutes are going to be bumped out of that blood, and then the blood continues on its way. You'll recall that the BCOP, blood colloid osmotic pressure, is that pressure to pull fluid back into the blood. You see these two blue arrows pulling fluid into the blood. These little purple arrows are pushing the fluid back into the capillaries as well. So there's opposing forces. You have this glomerular blood hydrostatic pressure moving this blood through, slamming those solutes out into the capsule. We have opposing forces here of the blood colloid osmotic pressure, capsular hydrostatic pressure, and then ultimately what's left over is whatever the give and take between those two opposing forces. That gives us our net filtration pressure. That filtrate is what it's now called. It's going to continue to what's known as the PCT, or proximal convoluted tubule. So let's look at some conditions that can result from issues with the glomerulus. One is albuminuria. This is protein found in the urine. Protein is very uncommon in the urine. Let's just take a look back here. These little slits, while they look very large, they're actually very, very small. And protein molecules are very large. They're actually too large to fit through there. An instance of actually having protein in the urine would mean this afferent arterial blood pressure is very, very high, high enough, in fact, to push those proteins out of the glomerulus and into the filtrate. So this condition, albuminuria, is going to indicate that that filtration membrane is damaged. This could be because of that high blood pressure, as I mentioned, damage to the kidney cells, kidney disease, or maybe an injury to your kidneys where they're not performing appropriately. Let's talk about the glomerular filtration rate, that GFR. This is the rate at which fluid is filtered within that renal corpuscle. Roughly, it's always going to be a little bit higher in males than in females, 105 milliliters per minute in females, 125 milliliters per minute in males. You don't need to know the exact amounts for any test or quiz, but you should have a rough idea of the general number of the filtration rate. The degree of reabsorption of substances from the filtrate is going to depend on two factors: the concentration of those substances as well as the rate of the flow. So if the glomerular filtration rate is too high, those substances aren't going to be reabsorbed because the fluid's traveling too quickly. If the glomerular filtration rate is too low, waste are not being adequately excreted because the fluid's moving too slowly. It's being reabsorbed at a much higher rate because that rate of movement is so slow. So ultimately, the rate at which the fluid is filtered is this GFR. Let's talk about what is reabsorbed after that blood slams into the glomerulus, forming that initial filtrate concentration. There's going to be a degree of reabsorption that occurs as this filtrate moves throughout the nephron. Water's a biggie. Water's reabsorbed. Ions like sodium, potassium, chloride, calcium, magnesium, bicarbonate, phosphate, those are all ions that are going to be reabsorbed. Also glucose and any amino acids. Notice proteins aren't on here because proteins typically are not released or filtered at that glomerulus. So what is generally secreted? In other words, what makes it all the way through this nephron structure and eventually to the bladder? These are our nitrogen-based wastes like ammonia, urea, creatinine. These are drugs. Of course, that's how drugs can be detected in urine tests. They're filtered out through our kidneys. Some ions like hydrogen and potassium are also excreted because hydrogen and potassium play a role in our acid-base balance in our body. So, how is that decision made to either reabsorb or secrete a substance? It ultimately depends on the concentration inside that lumen. Whether that specific transporter is present, that's going to mean that reabsorption occurs. In other words, let me see if I have a diagram here. Oh, there's a whole video on it. Let me try to draw it out for you so you can get an idea of what I'm talking about. Remember, we have this idea of a nephron. Here's our glomerulus, here's the PCT, and then the nephron loop, and the DCT. Of course, this is not to scale, and not 100% accurate. But this red line is actually representing a tube. And along this tube, there's various degrees of reabsorption that's going to occur. In other words, let me switch colors briefly here. A bit of blue. So remember, here's our little glomerular capsule. In other words, when the blood flows in through that afferent arteriole into our glomerulus, all of those solutes are kind of knocked out here, slammed out in the glomerulus, captured by this catcher's mitt of the glomerular capsule, and then that filtrate continues on through the PCT, nephron loop, and DCT. Well, this tube that makes up this entire structure has in it little channels. I'll just make a few of them. Little channels, and of course this is really at the cellular level. It really wouldn't be this big. But these little channels are going to be the stations of reabsorption for various substances. So you may recall from earlier chapters that substances like water, that can just go easily through the plasma membrane. But other substances, charged substances, larger substances like amino acids, need to use facilitated transport or active transport even, and they need to use special carrier proteins through the cell membrane. And that's what these little black dashes are representing. These are representing the special membrane channels that are going to reabsorb potassium, for example, or sodium, or maybe a specific amino acid. So whether or not substances are reabsorbed from the filtrate depends on whether or not these specific dashes or membrane transporters are present. This, of course, will probably explain it a little better than my simple drawing just did. A little animation on renal filtration for you. Just went the wrong way. This animation here goes through renal reabsorption and secretion. So let's talk about various ion transport pathways. There is a transcellular route, a paracellular route, and an enzyme-dependent route. The transcellular route is where that solute travels from one side of the cell to the other. This is going to involve passive and active transport, symporters, antiporters, channels, as well as pumps. There's the paracellular route, which is when that solute is going to go between cells, going through the tight junctions between neighboring cells. So this is going to use some type of osmotic or electrochemical gradient, kind of like an action potential passing from adjacent cells. And then there's the enzyme-dependent route, which is where those solutes are changed through enzymatic reactions to facilitate various transport mechanisms. So the rate and the degree of reabsorption is, of course, dependent upon their concentration. High concentrations of a particular solute within that filtrate is going to lead to greater reabsorption. If that substrate is excreted in the urine, or rather that substrate will be excreted in the urine if the concentrations are higher than the number of transporters available. In other words, remember those little black dashes, if there's just not enough of those transporters to reabsorb, it's going to be secreted. Or if that filtrate moves too quickly, in other words, that GFR would be very, very low. So let's talk about reabsorption within that tubule. Almost 2/3 of the water and solutes that are knocked out at the glomerulus are going to be reabsorbed at the PCT. Urea, creatinine, ammonia, and hydrogen ions are also going to pass through that PCT into the nephron loop. The fluid within that PCT is isoosmotic to blood plasma. So in other words, that fluid that is leaving the PCT tends to have the same osmotic pressure as blood plasma in terms of ion concentrations. Once we get to the nephron loop, it's not just straight up reabsorption that's occurring. The reabsorption, the bulk of it's going to occur in the PCT. The nephron loop, which is the next stop through our nephron structure, this is going to use a very complicated mechanism called a countercurrent multiplier. Basically, there's an interstitial gradient of sodium chloride. The deeper in the medulla, remember the medulla is kind of the meat of the kidney, the deeper into the medulla, the more concentrated that osmotic gradient of sodium chloride is. That descending limb of the nephron loop is going to promote the reabsorption of water. And then as the filtrate travels through that ascending limb, that fluid is going to become more and more dilute. The ascending limb is not permeable to water. So in other words, water cannot be reabsorbed at that point in the nephron. Sodium chloride is going to be actively transported out of the filtrate, and that tubular fluid is going to become more and more hypotonic because it can no longer lose or gain any water, but it is going to lose lots and lots of sodium chloride. This is called the countercurrent multiplier. Ultimately, it's going to serve to concentrate the urine, minimize water loss, and help the body maintain proper blood volume and hence proper blood pressure. Here you can see a good summary of all of the things I was just going through. The reabsorption and secretion at the nephron. You see our glomerulus, afferent arteriole, blood's coming in, lots of solutes are getting slammed out, caught by this capsule, flows to the PCT. This is where the majority of reabsorption is occurring. In the nephron loop, we have the absorption of water, sodium, potassium being separated. Water is absorbed, reabsorbed, only in this descending limb. And when we say water's being reabsorbed, what we mean is back into the blood. Water's leaving this filtrate and going back into the blood. More sodium, potassium are that going to be absorbed in this thick ascending limb. The differences between reabsorption of water and sodium and potassium allows for this setup called that countercurrent flow or countercurrent multiplier. When that filtrate leaves the nephron loop, it's very hypotonic compared to the blood plasma, and then that urea is secreted here as well as in that PCT. In the DCT, you have sodium chloride as well as water being reabsorbed. This is actually not the last stop for reabsorption. Reabsorption can occur within the collecting ducts. So the collecting ducts are actually the last stop for any changes in urine concentration. In the late distal convoluted tubule and collecting ducts, sodium and potassium can be reabsorbed or secreted depending on the presence of various hormones such as aldosterone or antidiuretic hormone. The permeability of cells to water is regulated by that antidiuretic hormone. When that antidiuretic hormone is present, water channels are then inserted. If you remember, water channels are special transport proteins that are going to be embedded in the plasma membrane. So that presence of ADH hormone is going to tell the cells to make more of these special proteins by doing protein synthesis, and those special transport proteins are going to be embedded in the cell membranes and cause the reabsorption of water on this last stop in our nephron before the urine is formed. So I did mention some specific hormones there. Aldosterone is a very important hormone. This is where sodium is going to be reabsorbed, potassium is going to be excreted. That aldosterone has a big effect in the collecting ducts and distal convoluted tubule. Parathyroid hormone is going to affect how calcium is reabsorbed. Antidiuretic hormone is going to cause that water to be reabsorbed within that DCT and collecting ducts. This animation here goes through hormonal control of blood volume as well as blood pressure. So let's talk about urine. What is urine? Urine is that filtrate after it leaves those collecting ducts. Where is it going to go? It's going to go through the minor and major calyx, to the renal pelvis, to the ureter, to the urinary bladder, to the urethra, and eventually out of the body. There's some physical characteristics of urine. On average, humans produce about 1 to 2 liters of urine a day. Again, that's going to vary depending upon your own fluid intake as well as hormone levels. The color is usually a yellow or amber color, and that's because of the urochrome, which is a pigment produced when bile is broken down, as well as urobilin, that's a product of the breakdown of hemoglobin. Urine that's more concentrated is going to be darker. Diet, medication, even vitamins can affect the color of urine. Kidney stones can also produce blood in your urine. The turbidity or the cloudiness of urine is another characteristic. Odor, some types of urine are mildly aromatic, even becoming ammonia-like. Some people inherit a stinkier urine than others. The pH of urine is going to vary from an acidic to a basic, again depending on what you eat. High-protein diets are going to increase the acidity. Vegetarian diets are going to increase the alkalinity. And there's also a density or specific gravity of urine. That's basically the ratio of the weight of a volume of a substance to the weight of an equal volume of water. The specific gravity of urine ranges from about 1 to 1.035. The higher the concentration of your urine, the higher that specific gravity. So urine tests can ultimately be done to determine whether there's abnormal presence or abnormal metabolic processes or imbalances as well as disease conditions. This chart goes through a number of them. You should be familiar with some of them. It might be a good essay question for me to ask, give examples of some abnormal constituents of urine, but I wouldn't ask you specifically what the presence of ketone bodies in urine would represent. So let's talk about the bladder, another urinary system structure. It's a hollow muscular organ, can hold up to 800 milliliters, almost an entire liter of urine. And again, that's going to vary from individual to individual. There's special folds within the peritoneum to hold that bladder in place. males' bladders located directly in front of the rectum, whereas in females it's just below the uterus. It's smaller in females than in males because of its position, having to make room for that uterus. There's a layer of smooth muscle. There's actually 3 layers of smooth muscle related to the bladder. It's called the detrusor muscle. This is the muscle that allows your bladder to expand and appear round and pear-shaped once it's filled with urine. When it's empty, it looks like a deflated balloon, and it contracts to expel that urine through the urethra and out the body. So the urethra is basically that little tube leading from the floor of the bladder outside of the body. There's 2 sphincter muscles involved with the urethra. There's the internal urethral sphincter. This is around the opening of the urethra. This is an involuntary smooth muscle. And then you have your external urethral sphincter, which is a voluntary skeletal muscle. When children are being potty trained, it's this external urethral sphincter that is being trained for their bodies to learn to regulate better. Here you can see some of these structures, the detrusor muscle making up the muscular walls of the bladder. You see the 2 entrances from the ureters coming into the bladder. This special area, this kind of triangle-shaped area, is where all the urine will pool and then eventually fills up, making the bladder nice and round. Once the bladder gets to a certain size, and that size limit varies from individual to individual, certain stretch receptors will trigger the urination reflex in humans. So let's talk about the differences between male and female urethras. With males, this is probably obvious. This is much longer structure in males than in females. It passes vertically, goes to the prostate, special perineal muscles, and then down the penis. It also has a dual role, serving as a duct for urine as well as semen. In females, it's behind the pubic symphysis, embedded in the wall of the vagina. You have that external urethral orifice between the clitoris and the vaginal opening. It's shortened, it's shorter than in males, I should say, which is going to increase susceptibility for urinary tract infections, painful urination. It can be treated with antibiotics, as well as cystitis, which is the infection of the bladder caused from microorganisms coming in. Here you can see the different structures. The urethra in females is only for urine, whereas males, it's urine as well as semen. So the process of micturition, this is the fancy word for urination. It actually involves a reflex. As urine accumulates in the bladder, as I mentioned, that stretch reflex is going to stimulate the process of micturition. That's when you're sitting there and you say, ooh, I gotta go to the bathroom. Those smooth muscles and sphincter muscles are innervated by the parasympathetic nervous system that rests and digests. The cerebral cortex can suppress the reflex because you have that voluntary skeletal muscle, that extrinsic urethral sphincter that can be regulated via voluntary muscle coordination. So that's when the cerebral cortex comes in and says, whoa, you're not sitting on the toilet right now, you need to wait until you urinate. This is the overall process. As I said, it's the stretch receptors going to the parasympathetic nerves. Ultimately, the cerebral cortex can regulate this because of that external urethral sphincter. Of course, there's always urinary incontinence that some of us will experience from time to time, or perhaps at one point in our life or another. This is the inability to retain urine through loss of that sphincter control. So that bladder sphincter muscle weakens, causes urinary tract infections. This could be a side effect of medication. It could just be due to age. It could be a neuromuscular disease. It could be a trauma. For instance, childbirth in females can cause incontinence. Sometimes after women have a baby, they go through a few months of incontinence till their muscles regain strength. Constipation can cause incontinence. Prostate issues with males can cause incontinence as well. It's treated with medication, muscle strengthening exercises, as well as behavior modification and possibly even surgery. We'll stop here for part 2.